Hi everyone, and welcome to our module on seizures. So a seizure is a sudden alteration in a person's behavior, and it's something that occurs when there's transient brain pathology. So let's talk about the symptoms of a seizure. One of the symptoms most people think of when they think of a seizure is loss of consciousness, and that can happen, but there are also many other symptoms. Patients can have abnormal motor activity. Muscles can contract or relax or spasm without the patient wanting them to do so. Patients can have abnormal sensation. They can feel or even see or sometimes smell something that's not there. And there's a range of symptoms. So there are very mild seizures where patients just become unaware of their surroundings for a few seconds or minutes. These are sometimes called absent seizures. And then a severe seizure is the classic kind of seizure you may think of where the patient collapses and begins rhythmically contracting their muscles and shaking on the ground. That's called a tonic-clonic seizure. There are many causes of seizures, and one thing you should know is that many people have just one seizure and then never have another one. So just having a seizure doesn't mean you're going to have a chronic seizure disorder. Seizures are often provoked. Children have what's called febrile seizures sometimes when they have a fever. If you don't get enough sleep, you can have a single seizure. If you practice neurology near a college campus, you often see college students who have a single seizure because they've been up all night studying. Drugs and alcohol can provoke seizures, and then if your blood glucose level gets too low, those patients can have a hypoglycemic seizure. There are other causes that are more serious, things like tumors and strokes, and we only call it epilepsy when you have multiple unprovoked seizures. That's what epilepsy is. If you look at what causes seizures, you find that the causes vary by age group, so let's talk about the children first. Some of the most common things to cause seizures in children are genetic conditions like juvenile myoclonic epilepsy, which we'll talk about in a minute, and other inherited conditions that lead to seizures. Fever is also a very common cause of seizure in children, so is trauma. Congenital abnormalities, like some of the things we talk about in the neuroembryology module, can cause seizures. And then finally, metabolic conditions. So a metabolic problem that causes a seizure might be hypoxia, or some of these things I've drawn down here, like hyponatremia and hypernatremia, low magnesium or low calcium. In adults, tumors are very common causes of seizure, followed by trauma, stroke, and then infections like encephalitis and meningitis. And then in the elderly, stroke becomes one of the most common causes, followed by tumor, trauma, metabolic causes, and infection. If you're working in the emergency room and a patient comes in with a seizure, this is the workup that's typically done. Most patients get blood work because, as I said in the last slide, electrolytes can trigger a seizure. Most patients get an EKG because cardiac syncope can mimic a seizure. Part of working in the emergency room is learning how to differentiate cardiac syncope from a seizure. Patients sometimes get an EEG. We'll talk about that in a minute. Patients often get brain imaging to look for tumors or strokes. And sometimes you'll do a lumbar puncture if you have reason to suspect that the patient may have meningitis or encephalitis as a cause. This is what a person getting an EEG looks like. EEG is an electroencephalogram, and it records the voltages in the brain, and it's similar in many ways to the EKG recording the voltage in the heart. There are different leads, as you can see on this person here, and some of them record the frontal lobes, the parietal lobes, the occipital lobes, and there are characteristic patterns associated with different seizure disorders, and this is an example of an EEG output over here on the right. Seizures are classified into a number of different subtypes. Partial seizures are seizures that involve one discrete area of the brain, so a patient with a partial seizure may have motor abnormalities of one muscle group or sensory abnormalities in one location in the body. That's because one discrete area of the brain is being affected. In a simple partial seizure, there's no alteration of consciousness. In a complex partial seizure, there is alteration of consciousness. And what this means is, in complex partial seizures, the discrete area of the brain being affected is one of the areas that involves the control over consciousness. In generalized seizures, the entire brain is affected. There are a number of subtypes of generalized seizures. An absence or petit mal seizure often occurs in children. These children will simply stare off into space for a period of time. A tonic-clonic or grand mal seizure is the classic form of seizure many people think of when they think of a seizure. It involves a tonic phase where the patient contracts all of their muscles for 10 or 15 seconds, followed by a clonic phase in which there is rhythmic jerking. Atonic seizures are also called drop seizures. In this form of seizures, patients' muscles become diffusely flaccid and the patient drops to the ground. This can often mimic a fainting spell from a cardiac cause. And then finally, in myoclonic seizures, patients simply have rhythmic jerking of all muscle groups over and over. The difference between myoclonic and tonic-clonic is that there's no tonic phase in a myoclonic seizure where the patient diffusely contracts all their muscles for 10 to 15 seconds. And then finally, you should be aware that partial seizures can become secondarily generalized. So a patient who has evidence of a simple partial seizure After this has gone on for some time, may have that seizure become generalized and develop evidence of these features shown here. Some patients with seizures get what's called psychic symptoms, and this can occur with partial seizures in particular. And the higher cortical areas of the brain get affected, so patients may have dysphagia and trouble speaking. Sometimes they get this eerie feeling of familiarity of their surroundings, and they describe it as déjà vu, like they've been somewhere before. They can get distortions of time where they're confused about where they are. They can suddenly become afraid, or they can even hallucinate. So all these may look like symptoms of some type of psychic disorder, but they can be symptoms of a seizure disorder. Patients can get autonomic symptoms with seizures, and one of the classic ones is to feel an epigastric rising sensation in the abdomen. This is a common aura, we'll talk about auras in a minute, that precedes temporal lobe epilepsy symptoms. They can also get sweating and piloerection, which is their skin standing on edge, and they can have pupillary changes as well. Some patients get what's called an aura, and this is a warning before a major seizure. In reality, the auras are simple partial seizures where the seizure has only affected enough of the brain to give them a few symptoms, but not enough to interfere with consciousness. And patients with epilepsy will recognize their aura, and they can sometimes try to do something to prevent the seizure from becoming more serious. The aura symptoms depend on the area of brain that's affected, so if it's the occipital lobe, they may see flashing lights. And if the motor cortex is affected, they may get an isolated muscle jerking. This is called a Jacksonian seizure. And these are all auras that come before a major seizure as a warning. After patients have had a seizure, especially a grand mal or tonic-clonic seizure, they sometimes have what's called a post-ictal state. So this is the transition period from the seizure back to the normal state. And it's a period of brain recovery, and the patient will remain confused and have a lack of awareness of their surroundings. Sometimes they even have focal neurological deficits present. And the time can vary from a few minutes to hours. And the most important thing to know about this is it's part of how we differentiate cardiac syncope from seizures. If you faint from a heart problem, when you regain consciousness, you should be immediately aware of your surroundings and where you are. On the other hand, if you have a seizure, when the seizure stops, you'll usually have a period of confusion afterwards. And this helps us differentiate different causes of loss of consciousness. It's high yield to know that the temporal lobe is the most common site of partial seizures, and one of the reasons this happens is because patients get a condition called mesial temporal sclerosis. It's also called hippocampal sclerosis, and they lose neurons in the hippocampus. And this is an image of a patient's brain who has this condition, and you can see there's a white spot here in the temporal lobe on this side of the brain, and that's what you see in this condition. It's sometimes bilateral, sometimes one side more than the other, and you can diagnose it by MRI. Juvenile myoclonic epilepsy is a common cause of seizures in children, and it can cause absence seizures, myoclonic seizures, and tonic-clonic grand mal seizures. Children who have this condition usually get absence seizures first, often at about 5 years of age. And remember, absence seizures are those seizures where children just lose awareness of their surroundings for a few minutes. When they get a little bit older, they start to have myoclonic seizures where they get muscle jerking in certain portions of their body. And then after that, they start to develop grand mal seizures. And the hallmark of this condition, which is high yield to know for board exams, is that these patients will have myoclonic jerks on awakening from sleep. So they'll wake up in the morning and then one of their muscles will be jerking. Often the myoclonic jerks are shock-like irregular movements of both arms, so be on the lookout for that in a board question. Childhood absence epilepsy is a condition that affects children, and they have a sudden impairment of consciousness. Usually they just stare into space for a few seconds. There's no changes in their body or motor tone, and it usually remits by puberty. It's got a favorable prognosis. The classic description of this, especially for a board question, is a child who appears to not be paying attention in school. What's really happening is the child staring off into space because he or she's having absence seizures. There's a classic EEG finding that you should know. It's a 2.5 to 5 Hertz wave spike superimposed on normal background EEG findings. And importantly, there's no post-ictal confusion here. When the seizure ends, the child comes right back to full awareness. There's a special seizure medication we use for this condition called ethosuximide. It blocks thalamic T-type calcium channels, and we really don't use it anywhere except in kids who have absence seizures. Febrile seizures are very common in children. About 2 to 4% of children under 5 will have one of these. The child will lose consciousness and begin to shake. It can be very traumatizing for parents, but it turns out to not be a serious condition. A child who has one is at risk for having more of these, but overall the prognosis is good, and most kids outgrow them as they get older. And this is not considered epilepsy. This is just a reaction to a fever. Eclampsia is another cause of seizures, so this is a pregnancy condition. So usually in the late pregnancy period to the slightly postpartum pregnancy period, this can occur. And so hypertension, proteinuria, and edema is preeclampsia. But then if seizures get superimposed upon preeclampsia, that's called eclampsia. And women having seizures from eclampsia need to be treated with magnesium sulfate. It's a very special drug that we only use for treating seizures in this situation. For the remainder of this module, I'm going to talk about the treatment of seizures, and this can be a confusing topic for medical students because there are so many different drugs that are used. I'm going to try to break the drugs down into classes for you and give you a framework by which you can remember them. But before we get into the drugs, we need to talk about what are the clinical circumstances when we would use a drug to treat seizures, and there are basically two of these. The first circumstance in which we will use a drug to treat seizures is when a seizure will not stop on its own. Many seizures are self-limited, but if seizure activity is ongoing, this can be life-threatening to the patient, and in these circumstances, we will use a drug to break the seizure activity. There is a condition known as status epilepticus, which refers to ongoing seizure activity, and this can be life-threatening. The former definition of status epilepticus was a continuous seizure that lasts more than 30 minutes, or a seizure that recurs in less than 30 minutes. There have been revisions to this definition, but the point is that status epilepticus is ongoing seizure activity that is not stopping on its own. And this is a medical emergency because ongoing seizure activity can lead to cardiac arrhythmias, lactic acidosis, hypertension, and many other life-threatening conditions. The second clinical circumstance when we use drugs to treat seizures is for prevention. So there are some patients who have conditions where seizures recur. Maybe it's every few hours, maybe it's every few days or weeks or even months. But the point is the patient is vulnerable to recurrent seizures, so we will administer a drug every day to try and reduce the risk that seizures will occur. In these circumstances, we're not giving drugs to break seizure activity, we're giving drugs to prevent seizures from occurring in the first place. So first we'll talk about breaking seizures in status epilepticus. And the thing to know here is that the first line treatment is benzodiazepines. Usually we use Ativan, which is also called lorazepam. It's very rapid acting and it works very well. Now, if the lorazepam is not working, you'll sometimes administer phenytoin or fosphenytoin, which is the IV version of phenytoin. We'll talk more about phenytoin in a few slides, and this will help prevent recurrent seizures. Now, some patients will still seize after they've been given benzos and loaded with phenytoin, and then you can try phenobarbital, and if that doesn't work, we often have to give general anesthesia and intubate the patient because the recurrent seizures are dangerous. And then while they're sedated and intubated, we'll try to load them up on medications to prevent further seizures. Preventing seizures is very different from breaking status epilepticus. Here we have a number of oral drugs that patients can take chronically to decrease the likelihood that they'll have seizures. Generally, drugs for preventing seizures fall into two categories. Some are sodium inactivators, and you may recall that sodium is necessary for the depolarization of neurons, so if you block sodium channels, you make it less likely that there will be neuronal activity. And these are drugs like phenytoin, carbamazepine, lamotrigine, and valproic acid. And valproic acid is here and here because it has multiple different effects. The next group of drugs is GABA activators. So remember, GABA is an inhibitory neurotransmitter. So if you increase the activity of GABA, you generally lower the amount of neuronal activity, and that makes seizures less likely. And these are drugs like phenobarbital, tigabean, vigabatrin, and valproic acid. Then there are drugs down here that have other mechanisms like gabapentin, topiramate, ethosuximide, levetiracetam, and primidone. We'll talk about all these in this module. A hard part of remembering these drugs is that all of them work for lots of different kinds of seizures. So these two are the easiest to remember. Status epilepticus always gets treated with benzos, and absence seizures always gets treated with ethosuximide. So make sure you at least know that. The others are going to be much harder to remember. Before we talk about any of the drugs, let me mention teratogenicity. So all anti-epileptic drugs carry a risk if taken during pregnancy. And you should know that valproic acid carries the greatest risk. It's the most teratogenic, and it's got about a 2 or 3% chance of causing neural tube defects like spina bifida. So the first drug we'll talk about is carbamazepine, which is also called Tegretol. It's a sodium channel blocker, and it's useful for partial and generalized seizures. It's also used in some other conditions. We give it to people with bipolar disorder, and it's very effective in trigeminal neuralgia, which is an extremely painful condition causing pain in the facial region from the trigeminal nerve. It's got many, many side effects, and it's hard to remember them all, but I'll tell you about them, and hopefully they will stick. It can cause people to have blurry vision and loss of balance. It can cause dangerous low blood counts, like agranulocytosis, which means no white blood cells, and aplastic anemia. You have to monitor the CBC on patients taking this drug. Carbamazepine can cause other bone marrow suppression, so low platelets as well, and again, you need to monitor the CBC. It can affect the liver, so LFTs need to be followed. It can cause SIADH, which is the syndrome of inappropriate antidiuretic hormone, and basically this drug makes the collecting tubule more responsive to ADH, so more water gets retained, and the sodium level will get low. If you're presented with a patient in a board question with a low sodium level, and they're taking carbamazepine, it may be a side effect of the drug. They can get a dangerous skin condition called Stevens-Johnson syndrome, which I'll talk about in a minute. And importantly, drug levels need to be monitored. So you can check a Tegretol level, which is carbamazepine, and see if it's therapeutic. And you don't want it to get too high because then these side effects are more likely to occur. So Stevens-Johnson syndrome is a rare life-threatening skin condition. It starts with malaise and fever, and it's often misdiagnosed as a viral upper respiratory infection. But then patients get extensive skin lesions, their skin necroses and sloughs off, and it can be triggered by a lot of meds, but a high-yield thing to remember is that many anti-epileptic drugs can cause this. So if you're presented with a patient in a board question who has Stevens-Johnson syndrome, look for one of the anti-epileptic drugs, because that may be the answer. And I've written some of them down here: carbamazepine, ethosuximide, phenytoin, and lamotrigine. So we'll talk about ethosuximide again. It blocks thalamic T-type calcium channels. This is a very unique mechanism. There really aren't any other anti-epileptic drugs that carry this mechanism. It's the drug of choice in childhood absence seizures. It can cause Stevens-Johnson syndrome, and then it's got other side effects I've listed here: nausea and vomiting. Children can have sleep disruption on this drug, and it can cause fatigue and sometimes hyperactivity. Phenobarbital is in a class of drugs called barbiturates, and they all bind to the GABA receptor, but they have a different mechanism from benzos. So the GABA receptor is basically a chloride channel, and when it's activated, it lets chloride into the neuron, and this makes it harder for the neuron to fire. That's why GABA is inhibitory. So phenobarbital increases the duration that the GABA receptor is open, and there's more chloride into the neuron and less firing. Phenobarbital can cause myocardial and respiratory depression. It can also cause CNS depression, and this is worse with alcohol. For any of you rock and roll fans, Jimi Hendrix overdosed and died on phenobarbitals and alcohol, and that's the easy way I always remember these side effects. It's contraindicated in a really rare condition called porphyria, and this is an autosomal dominant heme problem, and patients who have this condition get attacks of abdominal pain, and phenobarbital can trigger those attacks. And then phenobarbital induces the P450 enzyme system. So let's talk about cytochrome P450 briefly now. It's a collection of intracellular enzymes, and they metabolize many drugs. So if you inhibit this system, the drugs metabolized by P450 will have their levels rise. If you induce this system, the drugs metabolized by P450 will fall. There are a number of anti-epileptic drugs that induce the P450 system: carbamazepine, phenobarbital, and phenytoin. So inhibitors of P450 are more dangerous because they cause drug levels to rise, and some inhibitors are cyclosporin, some macrolides, azole antifungals. I've actually seen a patient on cyclosporin get very sick because the patient was co-administered a statin, and we'll talk about that in a second. Now the good news is many P450 drugs are rarely used. So thiophalin, cisapride, tafenidine, these are drugs that used to be used a long time ago, and if you gave an inhibitor of P450, you could cause dangerous life-threatening side effects, but luckily we hardly ever use any of these anymore. There are a few clinically relevant possibilities in the modern era. So if you give a statin and an inhibitor of P450, you can cause rhabdomyolysis, and that's what I've seen happen to patients given a statin and cyclosporin together. And then warfarin is a drug that is partially metabolized by the P450 system, so giving these inhibitors can cause the INR level to rise in patients taking warfarin for anticoagulation. So on this slide, I've just written some inducers and inhibitors of the P450 system. So over here are inducers, and they will cause the drug levels to fall of compounds metabolized by P450. So alcohol can do this. Rifampin, which is sometimes used as an antimicrobial, phenobarbital, which is an antiepileptic, carbamazepine, griseofluven is an antifungal drug, and then phenytoin. Inhibitors, remember I said, are more dangerous because they can cause drug levels to rise if a drug is metabolized by P450. So isoniazid is a TB drug, erythromycin is an antibiotic, cimetidine is a drug we rarely use anymore for stomach ulcers. Azoles can do this. Grapefruit juice can do this, but if you just drink a little grapefruit juice every day, it's not a big deal. Some of my patients on statins read about grapefruit juice in the newspaper and come and ask me if it's okay to take a statin when they're on grapefruit juice. And then ritonavir, which is an HIV med. So next let's talk about phenytoin, which is also called Dilantin, and this is a very commonly used seizure drug that you're likely to see in clinical rotations. It inactivates sodium channels, and it's very useful for tonic-clonic seizures. It has a lot of side effects you should know about. One of the first ones is gingival hyperplasia. So look at this patient's mouth over here. The gums are growing out over the teeth at the top and at the bottom, and that's gingival hyperplasia. And that's sometimes a limiting side effect of this drug because it's cosmetically very awkward for patients. Patients can also get hair growth. They can get rashes on Dilantin. Patients need folic acid supplementation when they're on this drug because folate levels get depleted. They can have decreased bone density. If you take this for a long time, you can start to get signs of vestibular dysfunction like nystagmus and diplopia and ataxia. It's teratogenic, so it can't be used during pregnancy, and you can monitor the blood levels, so you send a Dilantin or phenytoin blood level, and you try to keep it within the therapeutic range for patients to treat their seizures but limit the risk of these side effects. Phenytoin has a special metabolism in the liver that you should know about, and it's called dose dependent. So low dosages of phenytoin cause a very small rise in blood levels because the drug is quickly metabolized, but higher dosages saturate those enzymes and then you see a rapid increase in levels. Phenytoin is one of the inducers of P450, but it's also metabolized by P450. And if you co-administer phenytoin with other P450 drugs, you can get alteration of levels. So as I said before, levels of this drug are often routinely checked. Valproic acid is a seizure drug that has both sodium and GABA effects. In terms of GABA, it increases the synthesis and decreases the breakdown, so you get more GABA activity, but then it also has effects on sodium channels. In addition to seizures, people are given this when they have bipolar disorder or acute mania. It's a mood stabilizer. It's very bad for pregnancy. I said this a few slides ago. It's associated with spina bifida. It's high yield to know that for your boards. People who take this drug can get nauseous and have vomiting. It's hepatotoxic, so you have to check the LFTs. Some patients on valproic acid get tremor, and then a lot of patients gain weight, and this can be a big problem for people who need this drug chronically. Levetiracetam is also called Keppra, and it's displaced most of the drugs you're going to be tested on step 1 of the boards. It's a very effective anti-epileptic. It's useful for many types of seizures. You can monitor the blood levels, and so you can titrate it to the desired effect for the patient and avoid the side effects. It's generally well tolerated with few important serious side effects. So on your clinical rotations, the two most common seizure drugs you're going to encounter are phenytoin, which is Dilantin, or levetiracetam, which is Keppra. These are the bread and butter that are being used every day, and these other drugs you learn about are not used so much anymore. Two other anti-epileptic drugs I'll mention are lamotrigine. It's a sodium channel drug, and this has been used in children for seizures, and there's been a significant incidence of Stevens-Johnson syndrome reported. So you have to discontinue this if a rash develops, especially in children. That's where the case reports were. And then gabapentin is a drug that affects calcium channels. Now, it's got GABA in the name because when it was first developed, it was thought to affect GABA, but it turns out that's incorrect. It affects calcium channels. It's also called Neurontin. And this drug can cause sedation and ataxia. It's sometimes used for neuropathies in addition to seizures. The last two epileptic drugs I'll mention are topiramate, which has both sodium and GABA effects. It's also used as a migraine drug. A side effect it has is mental dulling. Patients sometimes feel foggy on this drug. They can get sedated. It causes weight loss, and then topiramate is a weak carbonic anhydrase inhibitor, so you get more calcium in the urine when you take this drug, and that can increase the risk of kidney stones. Patients on topiramate are often told to keep themselves well hydrated to avoid stones. And then finally, primidone has an exact mechanism that we don't understand, but it's metabolized and becomes phenobarbital, and it can be used for seizures. It's also sometimes used in patients who have essential tremor. And that concludes our module on seizures.